Hi, I'm Dr. Seth Force. I am the Kamal A. Mansour Professor of Surgery and Chief of Thoracic Surgery at Emory University Hospital in Atlanta, Georgia. So if we are talking about stage 3 lung cancer, which means that there is mediastinal lymph node metastases, then there actually is a role, and it's been studied quite a lot, but the answer is not definitive, meaning that we know some patients with stage 3 lung cancer and mediastinal nodal metastasis will benefit from surgery. And in particular, is if they have isolated lymph node metastasis. So we're not talking about a large group of enlarged lymph nodes in multiple areas of the mediastinum, but more isolated to one area. And if we can give them pre-treatment or what we call neoadjuvant therapy, either with chemotherapy or chemotherapy and radiation, and eradicate the disease in the lymph node, then studies have shown going and removing the lung cancer is beneficial to survival, particularly patients who, when we take the lymph nodes out at the time of surgery, they were truly eradicated. They don't have any disease there. So there's definitely a role for that. We tend to reserve that more for patients who have better what we call performance status, because it's not so cut and dry compared to like stage 1 lung cancer, where we know we 100% benefit those patients with surgery. That's not the case with stage 3 lung cancer. Some patients will benefit and some won't. For stage 4 lung cancer, it's even less clear. And certainly we know that some patients will develop an isolated, we call oligometastatic cancer, meaning they'll have one spot somewhere else and nothing else. And we do biopsies, imaging, PET scans, and we don't see any other evidence of cancer. So we tend to often remove the metastatic lesion either first, especially if it's a brain metastasis. We want to get that out of there, and often they get radiation to their brain while they're getting chemotherapy as well to treat the main lung cancer and the metastatic disease. And if after that treatment there's no evidence of any other disease other than the primary cancer, we will go and remove that cancer. That is a very rare scenario. It doesn't happen that frequently, but I have done that, more than a handful of times in the last 17 years. Another even less common is an isolated adrenal metastasis. So rarely we will go in and either give chemotherapy first and remove the adrenal metastasis and the lung lesion at the same time, or separate those out. So, I mean, those are the most common surgeries. The other, which is probably not what people think about, but oftentimes when patients present with metastatic lung cancer, it causes a significant amount of fluid to build up in the chest surrounding the lung. That can put pressure on the lung and really make it hard for patients to breathe. So there are procedures where we can go in and drain the fluid and then do one of two things: either leave a drainage tube in there called a Plerex catheter, where patients can go home and drain that daily. And typically within about 6 to 8 weeks, the drainage will stop and the tube can be removed and the fluid will not return. Or we can do a procedure called a pleurodesis, where we actually go in and put an irritant into the chest after we drain the fluid. Typically it's sterile talcum powder, which causes an inflammatory reaction and causes the lung to stick to the inside of the ribs and obliterates the space so the fluid can't collect. So that's obviously, those are what are called palliative procedures, meaning they're not going to extend the patient's life, but they will improve their quality of life as they're being treated for an advanced stage cancer.